Never assume or guess about documentation. Let's say a physician has a question. If they honestly don't know the answer, they need to be honest and say, I don't know, but I will find out.
When I started in cardiology over 15 years ago, I was actually placed where the providers turned in their charges. So this forced them to see me and for us to build that relationship. And it was actually the key to me growing professionally.
Welcome to MedAxiom Heart Talk, the podcast where thought leaders come together for one ultimate goal: to continually transform and optimize cardiovascular care for all. MedAxiom Heart Talk starts now.
This is Cheryl Toth, host of MedAxiom Heart Talk. In a CV practice, good communication between physicians and the coding team is vital. But coders and physicians usually work in different areas of the practice, often in different buildings. Everyone's schedule is packed. So when coders find inaccuracies in a physician's coding or missing elements in documentation, it's often tough to communicate them. So today, we're going to discuss some of the ways to overcome these challenges, as well as some practical strategies for keeping physicians informed and up to date with ongoing coding changes. And to do that, our guests today are MedAxiom Revenue Cycle Consultants Joline Bruder, calling in from Peoria, Illinois, and Jammie Quimby, who's joining us from Jacksonville, Florida. Both of them have significant experience in cardiovascular services coding, auditing, compliance, and operations. So Joline and Jammie, both of you, welcome to MedAxiom Heart Talk.
Thanks, Cheryl.
Thank you.
So Joline, let's set the stage. Tell us about the foundations that you feel create effective interactions between physicians and coders. I mean, you just wrote this fantastic blog that's on the MedAxiom website about this. What do practices need to do?
Well, thank you, Cheryl. And actually, I was going to mention the blog, so thank you for bringing that up. I would say the first thing that the practice needs to do is make sure that the coders and physicians actually know each other. And that can be done in a variety of ways. They can set up, little meet and greets, maybe breakfast with the physicians. And even if you can't get all of the physicians and or all of the coders together, at least get that ice broke if that hasn't been done yet.
Yep.
And then once that's out of the way, the coders and physicians then have the responsibility to hold up their end of the bargain for maintaining that relationship. So, for instance, coders need to make sure that they are giving honest and accurate and the most up-to-date information to that physician. And they should never assume or guess about documentation. Or let's say a physician has a question. If they honestly don't know the answer, they need to be honest and say, I don't know, but I will find out. And that's how I establish trust with the physicians I work for. Go ahead.
Well, and I love that you raised that point in the blog about how, you sat down with the physicians and you established that relationship. And some of the ways you did it were to make sure that you were always transparent and honest when, maybe you weren't sure, but you could go get the answer to the question. I think that's great advice. And how else would you lay out foundations and suggestions you have for that?
Well, the other thing is, the physicians need to exercise patience with the coders and remember that, they're not their enemy. You are on the same team. They're trying to do right by the physicians because they want to make sure that, number one, they're being paid correctly for what they do. They're also trying to make sure that the documentation is clear, not only for Medicare, but for the legalities. If they get hauled into court, they want to make sure that that documentation is very clear. So that coder can provide that good feedback and give them direction. And then and leading into that, the most important factor is the coders do need to provide feedback. You can't fix something if you don't know it's wrong. So if there's no communication there, nobody's going to come out of this good. So, it's very important to provide that feedback, and it's important for the physician to ask questions. All too often, especially physicians that have been doing this for a while, they tend to forget that things change continually with CMS and Medicare and even your commercial payers, and things that maybe it was okay to document this way 10 years ago, that's not the case now.
Well, and you brought up this issue of giving the physicians the feedback they need, things change and all that. The confidence, though, for a staff person to do that, I'd be curious, either you, Joline, or Jammie, how do you suggest to the staff they get that confidence? How do they garner that confidence within themselves to have it? Because let's face it, a lot of times folks are in the billing office, and coders and other staff are kind of maybe a little nervous about having a direct conversation with the doctor. So what do you suggest?
Well,
yeah,
that's a good point.
I was just going to say that the confidence comes with time and gaining that experience, looking at their records. So, of course, gaining the provider's trust is essential in our line of work. A lot of practices unfortunately have had to move their coding to off-site locations, or have even moved their coders to working remotely from home. We are finding in those instances that providers often don't even know who is coding and reviewing their documentation anymore. If the provider does start seeing a trend in their codes being changed without any feedback, this can often cause conflict and distrust. Having those coders on site is so helpful in promoting that physician-coder relationship. When I started in cardiology over 15 years ago, I was actually placed where the providers turned in their charges on a daily basis. So this forced them to see me and for us to build that relationship together. And it was actually the key to me growing professionally in the cardiology specialty. I used to pick their brains on a daily basis. Some would try to ignore me, but I wouldn't let them get away with it,
Right. So, Jammie, also let's hear your perspective on what should physicians expect from the staff when it comes to the coding accuracy. I mean, are there reports or benchmarks they should be expecting to receive, especially when these coders, like you say, are off-site now in so many cases? You don't have that place to see each other. But how should staff be supporting doctors, and what should physicians expect from them?
Yeah, so first off, the physician should expect that their staff is knowledgeable in coding their documentation. But with that being said, they should also be investing in their coders' education. There's seminars that they can go to. And now with the virtual world that we're living in, there's a lot of virtual coding summits that the coders can attend. Some of these are very inexpensive to attend. So really staying up to date, that can be challenging in our industry because these carriers can often change the rules on us, on a weekly basis. So if those resources are lacking, it will make it difficult for that coder to stay the most up to date. It's also important that physicians stay involved with their coding. So understanding the rules and the regulations is especially important in our area. If the coder has that relationship with the provider and is able to communicate with them and ask them questions, it will only help the coder's knowledge. In my own personal experience, I used to go to my providers when I wanted to understand more of what they were doing and why they were doing it. It did help me tremendously in understanding the documentation that I was looking at and the type of procedure, and more so what the provider was actually performing.
Oh, so how did you gain that knowledge about the actual procedure? How did you learn that? So
some providers have the ability to let the coder go into, like, if they're doing like a cardiac cath, they may have the ability to let the coder come and visually see one performed. I did not get the opportunity to do that when I was in a practice, but what I would have the provider do is sit down with me and explain to me exactly what is involved in that cardiac cath or whatever type of procedure it was. And they would kind of explain it to me in a language I would understand since I'm not clinical. I was more so just, making sure it was being coded correctly and the documentation was meeting that code that, they were wanting to report. So getting that visual from them, explaining it that way to me really helped me understand what they were doing.
Well, that's great. And Joline, I mean, that sounds like something that staff should expect of physicians, to maybe help them understand the procedure. I know it's one of the things you discussed in your blog. What else do you feel staff should expect of physicians when it comes to coding and documentation?
Well, Cheryl, they should actually expect timely responses from their physician. So if they have queried the physician should be responding, I would say, at least within 5 to 7 days. If they're doing it electronically, if they can set aside time to talk to them, that's great too. But the other thing is charges should also be turned in on time. Mm-hmm. The dictation needs to be completed on time. There was a doctor I worked for a long time ago, and he was horrible. I mean, there were sometimes it'd be 6 months before I get the dictation. And, it's kind of like, how can you possibly even remember what you did to this person? But, so things like that, that's an expectation that should be fairly easily met. And then also physicians actually need to provide details in their documentation of what was done. Now, that doesn't mean it has to be lengthy, but it does have to be detailed. It should be very clear what happened during that encounter, whether it be in the office or in the cath lab or in the OR. And one of the things I've told physicians before is I always give the 5 W's as an example: who, what, where, when, and why. Mm-hmm. And if they hit those 5 things, their documentation is going to be pretty good, because it's going to tell us who they treated, who else was involved, like with surgeries, if there's a co-surgeon or an assistant, what they did, where they went. So like with a heart cath, did they place that cath in the, left anterior descending artery, things like that. Finally, the why is they need to establish that medical necessity. So why did we do this? So that always has helped my physicians when I've done education with them.
I think that's a great way of thinking about it. And especially that last one these days, the medical necessity question really has to get answered. And physicians can't expect that the staff are going to know that. So for physician listeners, it's important, I think, that they recognize that these are the things that you've got to make the time, turn your stuff around in a timely manner, and make sure you deliver all 5 W's. I like that, 5 W's. So to both of you, let's say now there's a good relationship, communication is flowing, maybe there's good timely return of documentation so the coders can code it and it can get out and submitted. But now the coders have identified a coding or documentation issue, problem, however you want to say that. What's the best way to handle it when staff uncover that? How do they approach the doctor? What do you find works?
So in my experience, when I was still in a practice, the best way to start is by tracking the issue that you identify. So keeping a log of the patterns that you're seeing, that way you immediately want to let, management know, whether it's a coding manager, the administrator of the practice, the lead physician of the group. You definitely want to provide that feedback when you're seeing a trend. And sometimes it may not be the provider that needs the education when you see a trend identified. Sometimes it could just be the staff who's entering in those charges. Sometimes, they may need an up-to-date refresher on the guidelines and policies that are in place. So if you do see a provider documentation specific trend, then again, notifying the appropriate management within the organization is key, because they can help assist you getting that education scheduled with the providers.
That's great. Joline, do you have any other suggestions, things you found work?
Yes, I'd like to add, now, some of your physicians, it's going to depend. Some of them are very, they want to be personal. They want to sit and meet with you in personally. They don't like email. But then you have those that do like they prefer the electronic communication. So it kind of depends on that. And as you get to know the physician, you'll know, what works best depending on which physician you're dealing with. And then also the big thing is, as Jammie said, you need to identify it quickly, and then keep track of it, of what's going on. And then if that coder is not actually comfortable addressing the issue, then like Jammie said, get their supervisor, manager involved. And then, on the physician side of it, they need to be receptive and again, realize that the coder's there to help them improve their documentation.
Well, I really like what you said just now about, and I'm thinking of it as know your audience. Like you said, some doctors want it by email, some want it in person. So coders will find a real advantage if they take note of how people want it and recognize that they may have to deliver that information differently to different doctors for better success. It sounds like they can handle it more successfully. I would also ask the two of you, when this is an issue of maybe more of a delicate issue, maybe leading down a potential audit risk or something, when is it not appropriate for a coder to address the delicate coding issue in a conversation with the doctor?
One of the biggest things is it's never appropriate for a coder to tell a physician how to practice medicine. So, and I've heard this when I was a supervisor, I've seen it in consulting. Coders from time to time will say something to the effect of, well, he keeps performing this procedure and he can't do it because we're not going to get paid. And that happens. I mean, it does happen, but that's probably not the best approach. So I used to tell my doctors, I'm not telling you how to practice medicine. I'm telling you what I can legally bill for and what you can legally be reimbursed for. Mm-hmm. So for example, if they do think a patient needs a procedure and they haven't met that medical necessity, that's fine as long as the provider realizes they may not get reimbursed for it. And then if it's becoming a huge issue, then again, you're going to want to take that to management, because there'll come a point where the hospital won't get reimbursed either, and they're not going to put up with it. But, in light of that, they just have to tread carefully. And I never, ever tried to act like that I was a physician. The other thing I do always tell the coders as well, point out positive things that they're doing with their documentation. Don't just always focus on the negative.
Yeah, I think that's real smart. So then they know what they're doing well, so they can you can move on to the other things that maybe need some more, some modification or improvement, if you will, education. Jammie, what do you think? What have you seen or heard coders say that maybe they shouldn't have, or what do you recommend to stay away from in these conversations?
Yeah, so as a coder, you don't want to list your personal feelings or opinions on a matter. Providers really want the facts. They like to see it in black and white in the guidance. So sometimes the guidance is not always black and white for us, as we all know that. It can be gray at times. It is always best, though, to show the guidance as it is stated and help that provider understand the language that is in that guidance. So again, just keep your personal feelings and opinions out of it and just state facts, and that will help the provider understand.
Just the facts. Have more success with just the facts than opinions. That's great. Well, listen, let's take a break, and we are going to be back and continue the conversation about how to build that relationship, how to have good communication with physicians. And we will be back in just a moment with Joline and Jammie. Don't go away. You're on MedAxiom Heart Talk. Looking for a convenient way to polish your coding skills, or be sure your coding team's education is up to date? MedAxiom's Cardiovascular Coding Essential Education Series is a great solution. This 9-module online course is designed to teach coders, billers, and other revenue cycle staff the basics of coding for professional cardiovascular services. It covers the principles of medical coding for CPT, ICD-10, and HCPCS Level 2. Led by MedAxiom's expert Revenue Cycle Solutions team, The course is recommended for staff who are new to coding CV professional services or anyone who needs a refresh of CV coding essentials. Plus, all learners earn 13.5 CEU credits. To register, go to medaxiom.com/MedAxiom Academy and select the Cardiovascular Coding Essential Education Series. We're back, and we're talking with MedAxiom Revenue Cycle Consultants Joline Bruder and Jammie Quimby, and we are talking about how to have good communication between coders and physicians. And Joline, I am wondering what you think staff can do when the coding conversation goes, I guess you could call it like wrong or sort of sideways. Any examples you've seen or heard and ideas about what staff can do?
Sure. Well, I guess first and foremost, if you know the conversation is going south and you can't bring it back to where you have a mutual agreement, then my best advice is to end that conversation and then get your management involved. It's also important not only for administrators, but if you have a physician in a leadership position to actually back up the coder, and that's providing the coder is correct, that can help with some of those situations where you have a provider that's a little more brusque than others. But sometimes, and as Jammie pointed this out in an earlier question, if you have the facts and examples and you go through that with a physician and basically state, I agree with you, I understand, but this is what regulation says, and this is what I have to follow, things like that. And then another tip I guess I would give is whether or not this conversation is going to be successful is based on a couple of things. One is the approach. So you never want to go in with, guns blazing and put the physician on the defensive to begin with. The other thing is timing, and timing is very important. So I mentioned this in my blog that, probably the middle of a busy office is not the time to go up to the physician and say, hey, I have a question. Mm-hmm. So, if you can't get their attention at that time or whatever with things going on, then I always recommended too to schedule time, talk to their nurse, talk to their scheduler, find out if there's, maybe before office, maybe during lunch, maybe even after office, and get with them at that time.
Yeah, I think that timing issue is so important because you have bad timing and you don't know what you're walking into. I mean, the physician could have just had a really challenging, so many people on the schedule or a challenging procedure, whatever it is, and their mind is one place and you're trying to get them to another place, and then it's just frustrating. So I think that's very smart. Jammie, we talked a little bit about how a coder can have the confidence to have that conversation with the physician when they find a coding issue. How can they explain effectively why the coding issue and how to address it in a way that's mutually beneficial for both of them?
Yeah, so like I said, it's always best to come in with the facts. So even if that means you have to print the guidance, say you're in the office setting with them, you have some scheduled time with the provider, I would print examples for the provider. You could even print their case examples that you're finding a trend in, and then print those guidelines and, make it short and sweet, highlight the key areas that they need to see, and that will help them understand better what they can improve on with that documentation.
I think that is such a great tip. I've seen that where people will take literally print it out, take the highlighter, highlight something, and then show what the physician did and what the correct one would be according to the guidelines, and really talk through it from the perspective of that physician's patient and case, so that they understand it. And I think that's such a great tip. And how about getting ahead of the coding inaccuracy issue and avoiding the mistake altogether? Joline, I'm interested in what your thoughts are on how practices could think proactively. What could they do ahead of time? Is it charts? Is it, here are 3 things to read this month? I mean, how would you suggest they proactively keep physicians inaccurate coding?
Well, probably the best thing they can do is provide education, not only to both the coders, but the physicians. And another way they can do that is by doing internal audits. So if they're auditing and they see a physician is struggling, especially like with their E&M services. So if they're consistently not documenting enough review of systems, something to that effect.
Mm-hmm.
Well, when you do these internal audits, and it could be 10 records per provider, you bring them in, you sit them down, and then go over the fact that, hey, we're noticing you're missing these things, and a lot of times it's a small tweak. So that can backfire on you too if you throw too much at them. But the important thing is, my practice did it with me, and when I was in a practice, I became the lead educator. So it was my responsibility to make sure the coders were up to date on all the changes yearly.
Mm-hmm.
I also would go over those changes with the physicians. Now, with the physicians, I focused more on what they needed to document versus what the new codes were, because their eyes are going to glaze over. They don't care what the codes are. They want to know what the procedure is and what they need to document. And then another point that practices can do is to actually have an external audit done. If you can't do it yearly, maybe every year to 18 months, and have outside groups come in and drive home these points. Because a lot of times too, and Jammie and I have found this, when we go to practices, we'll sit down with the physicians and they'll say, hey, I've never heard this before. And we actually know they have, but sometimes if you bring in an outside person, it has more weight.
Yeah, more
with the
weight.
physician.
What do they say?
And
You're never a prophet in your own land. Isn't that the famous?
Correct.
I mean, it's so true, right? So you bring in an external person, and all of a sudden, oh, is that the case? They hear it.
Exactly.
So this has been great, you guys. I mean, lots of practical advice as well as some strategic communication thinking for people. Any final thoughts for listeners? Joline, let's start with you.
Well, again, we cannot stress enough the importance of having that physician-coder relationship. And even if not all of the physicians are receptive, there has to be at least one that's willing to listen to the coder. And a lot of times you can use that physician. He or she can go back to the colleagues and say, hey, we were talking about this, and they can help the coder educate the other physicians that don't want to take the time. And also, again, having that administrative backing, that's very important.
Mm-hmm.
If the administrator and the lead physicians do not back up the process, then you're at a loss. And then again, I want to stress, as Jammie said, trust is key. And once that physician knows they can trust the coder, the process goes much smoother.
Jammie?
Yeah, I definitely agree with what Joline said. That physician-coder relationship is just so very important in the practice. It just helps that trust be built between both the provider and the coder. It helps the coder in their confidence in approaching the provider and, further educating their own knowledge of the specialty. Cardiology is such a big specialty, in our industry. And, again, if the provider trusts you as a coder, it helps the coder in gaining that confidence and knowledge. And then remember, you guys are working together for the better good of the patient's quality of care. So again, just having that relationship is just so very big.
Excellent. Great thoughts, both of you. Really appreciate your time today, Joline and Jammie. Thank you for being our guests on MedAxiom Heart Talk.
Thank you.
Thank you.
And thank you, everyone, for listening today. If you like what you hear on MedAxiom Heart Talk, please refer us to a colleague. They can find us on Apple, Google, and many other podcast apps. If you've been enjoying our program, please take 2 minutes to review it on your podcast app. That really helps us out a lot, helps people find us. Or if you'd prefer to give us feedback directly, send an email to hearttalk@medaxiom.com.